This conference will now be recorded.
So yes, today we are going to see discuss this talk. Someone's mic is on. 1 minute. Shaista, please mute your mic. So today we are going to discuss this October 2020 talk, that is pelvic floor functional bowel disorders in gynecology. So remember, this talk is more about the bowel disorders, and basically the very untouched areas are discussed here. That is fecal incontinence, constipation, fissures, hemorrhoids. So these are the problems which usually the people come to gynecology. Females come, they don't want to go to surgery OP for this thing, and they usually come with the gynae OP. So for your day-to-day practice also, these topics are very important. And along with that, yes, definitely for your exam also, because this is a very untouched area. Nowhere we find the information regarding this. Okay, so the pelvic floor disorders, in general, they will include defecatory, urinary, and sexual function disorders, so which will usually contain urinary and fecal incontinence, pelvic organ prolapse, and pelvic pain. So these are basically pelvic floor disorders. So 23% of women, they experience at least one form of pelvic floor disorder. So prevalence of pelvic floor disorders is around 23%. Of this, 16% will experience urinary incontinence, 9% will experience fecal incontinence, and 3% they will have a symptomatic pelvic organ prolapse. These disorders, their prevalence increases with the age. So it is the prevalence is around 10% in the age group of 20 to 39 years, while 50% of the prevalence. So the age, when the age is 80 years or more, the prevalence of this pelvic floor disorder is around 50%. So today we are going, in this talk we are going to see only regarding the bowel disorder. So it is the whatever we are going to see is around most of the posterior compartment. Okay, so one is fecal incontinence. Of that, most of the talk this discusses regarding this fecal incontinence. Now fecal incontinence, when we call it as a fecal incontinence, so basic terminology is anal incontinence. So anal incontinence, it can be of fecal or flatus. Okay, so anal incontinence, it is an involuntary loss of either feces or flatus. Fecal incontinence means involuntary loss of either liquid or solid stool. So fecal incontinence is involuntary loss of feces, while flatal incontinence is involuntary loss of flatus, and which is flatal incontinence is more prevalent than this fecal incontinence. Now, urge incontinence, similar to that of urge urinary incontinence, it is similar to that. So it is inability to resist to urge to defecate, which results in not making it to the toilet in the time. Now, the fecal continence mechanism. Okay, so what is the requirement, prerequisites for this fecal continence? So these are intact anal sphincter function, rectal sensation, adequate rectal capacity and compliance, correct colonic transit time, stool consistency, and cognitive and neurological factors. So fecal continence depend upon all these factors. So incontinence occurs whenever any one or more of these things are affected. Prevalence of fecal incontinence. So it is very common and it affects almost 10% of adults and up to 50% patients in nursing home. So which are the vulnerable groups for this fecal incontinence? So women following childbirth, patients with urinary incontinence and pelvic organ prolapse, women with diarrhea, women who have colonic resection, anal surgery or radiotherapy, and learning disabilities and severe cognitive impairment. So these people are high risk group for this fecal incontinence. Now, whenever a patient comes with fecal incontinence, how you are going to assess that patient? So first of all, you should know regarding the nature of incontinence. So whether it is a fecal, flatus, so nature of incontinence, whether it is a urge or this thing, then you have to ask regarding the onset, duration, and what is the effect on the quality of life. Detailed obstetric history should be taken regarding complications during labor and delivery, because 13 to 25% of women who had vaginal delivery, they can be affected by anal incontinence. Now see, it is anal incontinence, not fecal. So it can be just the flatal incontinence also. So 13 to 25% of women who had at least one vaginal delivery, they can be affected by this anal incontinence. Then another predisposing factor is trauma or surgery of the perineum. And then medical conditions like diabetes, neurological or inflammatory bowel disease. Then you have to do the proper examination, which involves abdominal palpation, assessment for any prolapse, and anorectal examination. Here again, focus should be on warning signs for gastrointestinal cancer, prolapse, acute disc prolapse, and quad equina syndrome. So in this quad equina syndrome, it is associated with anal sensation loss. And then neurological and cognitive assessment should be also done. So this is I'm not going into detail of this, but you should know. So for incontinence, what is the quality of life or what is the score sheet which is used is St. Mark's incontinence score sheet is used. And here the score 0 represents perfect continence while 24 represents totally incontinent. Okay. So here basically they are considering the factors like incontinence for solid stool, liquid stool, gas, any alteration in lifestyle, need to wear a pad or plug, taking constipation medicine or not, and lack of ability to defer defecation for at least 15 minutes. So these are the factors which are considered here. So initial management of fecal incontinence. So initial management is the conservative management, which is lifestyle modification and pharmacological management. Okay. So lifestyle modification means the women who have hard stool, they should at least drink 1.5 liters of fluid per day. Food diary should be kept to discover any triggers. Okay. So dietary triggers which are responsible for this incontinence. Common offenders, these are caffeine, fructose, and lactose. Eating small meals, which will decrease the sense of urgency. Bowel movements at specific times. So what we call it as bladder retraining. It is like similar to that of specific time bowel movements. Then women are encouraged to use the toilet after a meal. And they should have access to private toilet facilities and sitting or squatting wherever possible. Then use of disposable pads, anal plugs, disposable gloves, and skincare advice to tackle this fecal incontinence, and emotional and psychological support, which involves counseling and therapy also. So this is the initial management, that is lifestyle modification. Now pharmacological management is the first line drug is the loperamide. So loperamide is the first line treatment for loose stools. It can be used for long term, but it should not be prescribed where the patient has hard or infrequent stool or acute onset of diarrhea. Then people who cannot tolerate this loperamide, they can be offered codeine phosphate or cofenotrop instead. So it is a opioid medicines which will cause constipation, correct? So for loose stools, you can prescribe this thing, but for hard stool, you should not prescribe this. And other conservative measures, they should include pelvic floor muscle training, bowel training, biofeedback, electrical stimulation, and rectal irrigation. Now, after this lifestyle measurements and conservative measurements, pharmacotherapy, if the patient is still unable to control the fecal incontinence, then specialized management should be done. And before specialized management, the specific investigation should be considered. And what are this investigation is? One is endoanal ultrasound. Okay, so it is the standard in investigation to evaluate the sphincter pathology. So endoanal ultrasound is the first line investigation. Here the probe is gently inserted into the anal canal and it is inserted up to the depth of 6 centimeter, and it is withdrawn slowly, and during withdrawing this cross-sectional images are obtained. So here what you are going to see is sphincter length, any damage to internal sphincter and external sphincter, puborectalis, longitudinal muscles, and anal mucosa. So all these things you are going to see for any abnormalities or any tears. Then anorectal manometry. So anorectal manometry, it is the measurement, objective measurement of the anal sphincter pressure. So this pressure should be measured at rest and during squeeze. So normal resting pressure is around 65 to 85 millimeters of mercury, and resting pressure, it should be measured in the region of 1 to 1.5 centimeters above the anal verge. And squeeze pressure should be created by contracting the external anal sphincter. And now the squeeze pressure, which is almost double to that of this resting pressure. So both the pressure, these are generally reduced in case of fecal incontinence. So resting pressure and squeeze pressure, both of these are reduced in case of fecal incontinence. So it is the anolectal manometry. And third thing is pudendal nerve velocities. Okay, so motor terminal motor latency velocities, they should be measured for this pudendal nerve. Normal value is 1.9 plus minus 0.2 millisecond, and the higher value shows that it is pudendal nerve injuries. So these higher values are seen in anal incontinence, injury of external anal sphincter, rectal ulcer syndrome, and treatment-resistant constipation. So pudendal nerve velocities, these are increased. And first line is internal ultrasound and anorectal manometry. So these three are the specialized investigation for the management of fecal incontinence. And after these investigations, then specific management should be done. So specific management is in the form of two forms. So one is the neuromodulation and another thing is the surgical. So neuromodulation, it is the percutaneous tibial nerve stimulation, which is a less invasive form, and sacral nerve stimulation. So sacral nerve stimulation, it is invasive, but it is effective technique for idiopathic and acquired fecal incontinence. So sacral neuromodulation, it is similar to that of what you are doing for this urge incontinence. Okay, so it is a two-stage procedure. First is a diagnostic stage where you are going to evaluate it temporarily, and if it is effective, then there will be a permanent placement of this implant. Okay, then so there are it is a two-stage procedure. One is temporary or diagnostic stage, and then followed by permanent placement. So if this neuromodulation is also ineffective, then you are going to go for the surgery. So now surgery, there are two or three things which are done in surgery. So one is the anal sphincter repair. So anal sphincter repair, it is indicated in case of full length of external anal sphincter defect, and which is 90° or greater on ultrasound, with or without an associated internal sphincter defect. So this procedure, it is performed perineally. Now the success rate for this procedure at the 5 years, it is around 70%, but it decreases over the time, and success rate at the 10 years is only 10%. So it deteriorates over time, this anal sphincter repair. So you have to explain to the patient. And again, the patients who have this internal sphincter defect, any pudendal neuropathy, external sphincter atrophy, loose stools, or irritable bowel syndromes, they have this decreased effectiveness of this surgery, that is anal sphincter repair. Another surgery which can use is bulking agents. So like collagen, carbon beads, or silicone particles, they are injected in the 3 to 4 places just above the dental line. So it will create an anal cushion, so which can be used for this continence mechanism, and it will stop the passive leakage. But still there is a lack of good quality data on the effectiveness of this procedure. Then another thing which are used, two surgeries which are used from the time being, these are stimulated gracioplasty, and another thing is artificial anal sphincters. So these two techniques, they can offer a chance of restore continence and improve quality of life when the sacral neuromodulation is not successful. So surgery is in the form of these four surgeries. One is sphincter repair, another thing is the bulking agents, and then stimulated gracioplasty and artificial anal sphincters. And patient which is not responding to all these things, and patients who have this fecal incontinence with severely restrict lifestyle, a stoma can be done. Okay, when all other non-surgical and surgical options, they are ineffective or they are not uh, feasible for that patient, then only stoma, that is colostomy, can be done. So this is regarding the surgical management of fecal incontinence. So now the next topic which it is chronic constipation. So chronic constipation, definition of chronic constipation is bowel movements which are infrequent or incomplete or need of frequent straining or manual assistance for defecation. This is a very common disorder. It affects up to 14% of the population. Severe constipation, it is more common in pregnant women with a prevalence of almost 40%. And it is also common in elderly women who are 2 to 3 times they are more likely to have than men. Okay, so elderly females are more likely to suffer from this chronic constipation. So this is the Rome 4 criteria for the chronic constipation. So here remember everything, which is all these symptoms, they should have at least 25%. Okay. So at least 25% of all defecations, this symptom should be present. So one is straining, another is lumpy or hard stool, sensation of incomplete evacuation, sensation of anorectal obstruction or blockage, and manual manures. Yes, Rome 3 for IBS. Okay. Manual manures to facilitate for at least 25% of defecation. And the last thing is fewer than 3 defecations per week. And the loose stools, they are rarely present without laxatives. And to fulfill this criteria, the symptom should be present for at least 3 months. And symptom onset should be at least 6 months before the diagnosis. So this is the Rome 4 criteria for the constipation. Now remember, nobody is going to ask you what is the criteria, but usually for IBS, like they ask which is the criteria which is used for diagnosis. It is a similar thing. They can ask you this in the SBA. Okay. So this is the Rome 4 criteria which is used for this diagnosis of chronic constipation. Another thing is drugs which can cause constipation, chronic constipation. So one is aluminum containing antacids, iron, calcium supplements, analgesics like opioid analgesics or NSAIDs, antimuscarinics like procyclidine or oxybutynin, antidepressants like tricyclic antidepressants, antipsychotics, clozapine, quetiapine, then antiepileptic drugs like carbamazepine, gabapentin, oxcarbazepine, pregabalin, or phenytoin, antihistaminics like hydroxyzine, antispasmodics like dicyclopyrin or hyoscine, and diuretics like furosemide, calcium channel blockers. So all these things, they can cause chronic constipation. Now this chronic constipation, it is divided into either primary or secondary. So in the primary, there are again 4 groups. One is slow transit constipation, another is obstructed defecation syndrome, third is constipation predominant with this IBS, and mixed slow transit plus obstructed defecation. So these are the 4 types in case of primary constipation. And secondary constipation, where you can have a identifiable cause like drugs or medical condition or painful hemorrhoids, ulcers or fissures. So constipation due to secondary causes. Another thing which is a functional, that is called as anismus. So here there will be obstructed defecation, but the cause is functional rather than the anatomical cause. So in anismus, what happens is paradoxical contraction of external sphincter and tuberectalis muscle when the patient tries to defecate. So actually when the patient tries to defecate, this anal sphincter should open, but here there will be paradoxical contraction of this external anal sphincter. So the woman who presents with anismus, they should undergo other investigations like anorectal manometry or defecating proctogram to identify other causes, anatomical causes for that matter. So conservative management for this chronic constipation, first is the lifestyle modification, that is dietary habits should be changed, increasing fiber intake up to 30 grams per day, adequate fluid intake, good toilet habits and exercise. And after this conservative management, the pharmacological management include stepwise oral laxative prescription. So first line is the bulk forming laxative, which for example is Sabul. Then after this, if this bulk forming they are not effective, then add or switch to osmotic laxatives like lactulose or macrobol. Even if these are not effective, then add stimulant laxative like Sena. So first line is the bulk forming, second line is the osmotic, and third line is the stimulant laxative. Then if the patient has opioid-induced constipation, you should not use bulk-forming laxative. Remember well, so opioid constipation, bulk-forming laxative should not be used because they will cause abdominal colic and bowel obstruction. In pregnancy and breastfeeding also, the management starts with the conservative management only. So first will be lifestyle modification like mentioned above, and then same stepwise approach for the oral laxative. And if this fails, then use a glycerol suppository in case of pregnant women. Now, other medical management is prucalopride, which is a 5-histaminic receptor, 5-HT4 receptor agonist, and lubiprostone, which is a chloride channel activator. So it can be considered when other laxatives fail to produce an adequate response. But they should be prescribed only by clinicians which are experienced in treating chronic constipation. Laxative, they should not be stopped suddenly, but they should reduce gradually, like over 2 to 4 weeks. Then when the regular bowel movements, they are comfortable with soft form stool. And weaning of these laxatives, it can take several months. The patient who have this slow transit constipation, the methods which can use are biofeedback, sacral nerve stimulation, segmental colectomy, or subtotal colostomy with various anastomosis. It can be used for this slow transit constipation. In case of anismus, that is contraction of this functional contraction of this external anal sphincter, here you can use botulinum toxin 20 units of injection in the puborectalis muscle, and it can be repeated every 3 months. Okay, and if there is no response to this treatment, then examination with anesthesia, it should be done to rule out rectal prolapse. Then obstructed defecation means normal desire to defecate but an inability to satisfactorily evacuate the rectum. So patient will have normal desire but she cannot. So it is basically incomplete evacuation. Possible mechanism it can causes, so it can be rectocele, enterocele, sigmoidocele, rectal interception or rectal prolapse. Then functional obstructed defecation syndrome, it can be caused by failure to relax, which will result in anismus. So here in obstructed defecation, the patient will present with straining, sensation of blockage, digitation and splinting. Okay. So investigation for this obstructed defecation. So you should do colonic transit studies. So here it is a radioacopic capsule is swallowed, and then on day 5, abdominal X-ray is done. If more than 80% of markers remain in the colon on day 5, then it is a slow transit constipation. Then defecating proctogram to identify any functional or anatomical abnormalities, and dynamic MRI defecography. So it is a superior to tissue contrast, and it is used to visualize pelvic fissura and supporting tissue structures. So here the radiation burden can be reduced. So now it is considered superior to this defecating proctogram. It is a dynamic MRI defecography. Management of this chronic constipation, obstructed defecation. So first is conservative measures, which is same like that of chronic constipation, like increase dietary fibers, use of laxative and enema. Physiotherapy also can be used, like altered position for defecation, like squatting, or rectal irrigation system can be used. Then rectocele repair can be done. So if the cause of obstructed defecation is rectocele, then you can do rectocele repair. So it can be done either transrectally or transvaginally. So in case of transvaginal you can do when the patient have other symptoms like cystocele or walled prolapse or uterine prolapse. But here the risk of postoperative dyspareunia will be there, and it occurs in 25% of patient and recurrence rate of 10%. When the transrectal approach is used, the dyspareunia will be less often, and here you can perform the surgery for a coexisting anorectal pathologies like hemorrhoids, anal fissures, rectal prolapse or arterial mucosal prolapse. So which is usually present in 80% of patients of this obstructed defecation syndrome. So regarding rectal prolapse, so it can be only internal rectal prolapse or interception. It is a full thickness rectal prolapse, but it does not protrude through the anus. And another, that is external rectal prolapse, where it is the full thickness extrusion of the rectum beyond the anal verge. So here the surgery which is used to treat this rectal prolapse, it is the Lom's procedure. So, but it has a high recurrence rate of 37%, and other procedures which can use for this rectal prolapse, these are staple transanal rectal dissection or laparoscopic ventral mesh rectopexy. So this laparoscopic rectopexy, mesh rectopexy, it has a much lower recurrence rate of 10% only. Then anal fissure. So it is one of the most common cause of anorectal symptom. It is a longitudinal tear in the skin of anal canal distal to the dentate line. So So here you can see, this is the dentate line and these are the fissures which are distal to the dentate line. So this is basically regarding pathology of all these bowel disorders or anorectal disorders. So here you can see this is the anal fissure. Here you can see it is the anal fissure, sorry, it is the anal fistula, and here you can see it is the anal abscess. This is anal abscess. This is fistula. So when it forms pus, in case of that, it becomes anal abscess. These are the fissures, okay? And these are the hemorrhoids. So which are above this thing, it is internal, above dentate line, internal hemorrhoids, below dentate line, external hemorrhoids. So acute fissure, these are superficial tears in mucosa. They become chronic when they extend through the submucosa and which will expose either internal or external anal sphincter, and it will cause hypertrophic. So it will also expose this hypertrophic anal papilla. So if they do not heal, if the acute fissure do not heal within 4 to 8 weeks of conservative therapy, they become chronic fissures. So 90% of fissures, they are found in the posterior. So they are posterior in location, which is the least perfused area of anal canal. So 90% of anal fissures, these are posterior. But in gynecological OPD, you can find more fissures which are anterior because these are associated with the pelvic floor staining, which usually occurs after the childbirth. And lateral fissures, when they are present, they usually occur with Crohn's disease, tuberculosis, and infections like HIV or syphilis or malignancy. So lateral fissures, they are usually associated with all these diseases. So assessment of this anal fissure. So basically you have to ask regarding the complaint. So which complaint most commonly, it is the pain on the defecation with a strip of blood on the toilet tissue. Diagnosis, which will be usually made by history and examination only. So just parting the buttocks, you can visualize the features. But here, per rectum examination, it should not be done because it is associated with excruciating pain. So remember well, PR examination should not be done for the fissures. Now, management of anal fissures, again, the lifestyle modification like increasing fiber intake, adequate fluid intake. So it usually heals up to 87% of acute fissures. And this should be increased gradually. So fiber intake, it should be increased gradually to avoid any bloating and flatulence. Warm sitz bath can be used to improve the perfusion. Then medical therapies, which include these are stool softeners and analgesia. If the defecation is painful, you can use topical anesthetic, that is lignocaine 5% ointment, or other preparation like GTN or calcium channel blockers ointment. But GTN, it is usually associated with headaches, so it is usually discontinued by patient. Diltiazem cream can be also used, but it is not licensed for this condition. Okay. So ointments which are used are lignocaine ointment, GTN, and calcium channel blockers or diltiazem ointment. Also here also you can use this Botox injections 20 units, and the effects usually last for 3 months. Then surgery for anal fissures, it is the internal sphincterectomy, fissurectomy, and anal advancement flaps. So it has usually the 85% of success rate, but risk of lateral incontinence is around 30%, and fecal incontinence is around 3 to 5%. Now, hemorrhoids, these are the enlarged mucosal venous cushions of the anus, which become symptomatic. So prevalence for hemorrhoids, it is around 13 to 36%. Hemorrhoids either can be external or internal depending upon the dentate line. So below the dentate line, external hemorrhoids; above the dentate line, internal hemorrhoids. Internal hemorrhoids, these are usually not painful because these are covered with columnar epithelium and no pain fibers. While external hemorrhoids, these are they are severely painful because these are covered by the anoderm, which is richly innervated by the pain fibers. Predominant symptom for hemorrhoid is bleeding, that is after passing stool, pain, mucus, lumps, and itching. But here the severity is unrelated to size because as I told you, The internal hemorrhoids, they are not painful. The pain will not be there for external hemorrhoids. They are severely painful. So as you can see, small hemorrhoids, they can be very painful, but sometimes large and asymptomatic piles, they are incidentally found in elderly patient because of this low anal pressures. So whenever you suspect any hemorrhoids, other differential diagnosis you should rule out like polyps, inflammatory disease, or malignancy. Then pain can be there because of fistula, fissure, or anal abscess, and lumps can be due to warts, skin tags, or rectal prolapse also. So all these things you should consider in your differential diagnosis, and you should rule out all these conditions. So this is again the localization of this thing. So hemorrhoids below and above the dentate line, internal and external, fistula, abscess, and the fissures. So grades of hemorrhoids. First degree, so hemorrhoids, they project in the lumen of anal canal, but they will not prolapse out of the anal canal. So it is the grade 1. Grade 2, it will project beyond the anal canal, protrude beyond the anal canal on straining, but they will spontaneously reduce when the straining is stopped. So it is grade 3. Sorry, grade 2. Grade 3, it protrude outside the anal canal even on resting, but they will reduce fully on manual pressure. And fourth degree, they protrude outside the anal canal and they cannot be reduced. Okay, so it is like a old prolapse classification. So first degree is only inside the anal canal. Second degree, protrude on the straining. Third degree, protrude at the rest but can be reduced completely. And fourth degree, they will protrude out of the anal canal and it cannot be reduced. Assessment of this hemorrhoid. So usually patients are examined in the lateral position, but internal hemorrhoids, they cannot be visible or palpable unless they are prolapsed. So per rectal examination, it should be performed to rule out other causes like other masses, any tenderness, blood or mucus, and proctoscopy is also used to support the diagnosis and rule out other causes. Management for hemorrhoids, it is again same conservative management, increase fluid intake and dietary fiber. So it will this alone can improve bleeding from grade 1 and grade 2 piles or hemorrhoids. The affected area, it should be kept clean and dry. Careful perineal cleansing, perianal cleansing should be done. Medical treatment, it consists of simple analgesics, but avoid opioids, which can cause constipation. And NSAIDs if it is bleeding, okay? And stool softness to avoid straining. Non-surgical treatment includes rubber band ligation, which has a success rate of 65 to 85%, but recurrence rate of 20%. Then other surgical treatment is injection sclerotherapy, infrared coagulation, and bipolar diathermy. Okay, so sorry, these are all non-surgical management. So non-surgical management, they will include rubber band ligation, sclerotherapy, injection sclerotherapy, infrared coagulation, and bipolar diathermy. And surgical management, it is stapled hemorrhoidectomy, which is also known as hemorrhoidopexy. So here you will excise a ring of mucosa and reduce this hemorrhoidal cushions. And then another surgery is hemorrhoidal artery ligation. Now another thing which is also known as solitary rectal ulcer. So it is a very rare and underdiagnosed condition. Prevalence is 1 to 3 cases per lakh population per year, and it is usually misdiagnosed as a cancer or inflammatory disease. This is caused by straining and increased pressure during defecation. What happens with this increased pressure is it will cause anterior portion of the rectal lining, it will force into the anal canal. So it is also called as internal rectal intersection. And the lining of rectum, it is repeatedly damaged by this friction, which will cause ulcer. So the patient will usually have symptoms of rectal bleeding, passage of mucus, pain, constipation, and incomplete emptying with unsatisfactory defecation and straining. Here, this disease, you should remember this is as a disease of 3 lives. Okay, so see here, name of the disease is solitary rectal disease, but all these 3 names, these are misnomers because these are not solitary. In 30% cases, there are multiple ulcers. Rectal means it is not only limited to rectum, but it can also occur in descending and sigmoid colon. And it is not usually ulcer on histopathology, but it is a polypoid lesion. So all these three terminologies, these are misnomers. So it is called as disease of three lies. Remember well. Okay. Treatment, it depends. Symptomatic treatment, where it is change of diet, bulking agents, and biofeedback. You can use topical treatments like sucralfate, salicylate, corticosteroid ointment, sulfasalazine, mesalazine, and topical fibrin sealant. And surgical treatment, it can be local excision, rectopexy, stoma, or anterior resection, depending upon the severity of the symptom. So for solitary rectal ulcer, remember that it is a disease of three lies. So basically here the main purpose of this talk is to, because all these are bowel disorders, but they can be frequently presented in gynecology OP or general practice OP. So here basically the role of the multidisciplinary team is there. So all this pelvic floor dysfunction like pelvic organ prolapse, fecal or urinary incontinence, or obstructive defecation, they usually coexist, and here the multidisciplinary approach is required. So MDT meetings, these are recommended by NICE for these conditions, and these are attended by urogynecologist, colorectal surgeon, urologist, radiologist, physicist, physiotherapist, and specialist nurses. So the whole team, they will review the history, examination, and investigation, and then most appropriate treatment option is given. And these patients, these are discussed as MDT, and then these patients are usually followed up in the pelvic floor clinic. Okay, so these are specialized pelvic floor clinics for these disorders. So this is regarding this pelvic floor dysfunction, which is associated with these bowel disorders. Okay, so this is the talk. Remember well, this has discussed very common conditions. So please go through it, and this can be very important. I don't know how much it is useful for Jan exam, but definitely for July exam, you are going to get 1 or 2 questions from this talk. So thank you all of you for attending. Bye. Tomorrow we will meet with another talk. Okay.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.